Hello and welcome to this edition of Top of the Morning. Today we're talking about something that may be close to your heart, literally. On set today are two doctors from MultiCare's Pulse Heart Institute to discuss the subject of cardiac catheterization and percutaneous coronary intervention, Dr. Hira and Dr. Pujeda. PCI is a non-surgical procedure used to treat the blockage in a coronary artery. It opens up narrowed or blocked sections of the artery, restoring blood flow to the heart. According to Yale Medicine, 900,000 PCIs are performed every year. It sounds pretty routine, and even though the procedure is life-saving and to no small extent life-altering, the procedure still involves the heart with some minor risk. Am I correct, Dr. Pujeda?
Because of that, because of the nature of the procedure and the equipment that we use and the aggressiveness of the techniques, there's also a higher risk of complications compared to the usual angioplasty that we do. So it's very, if you may, technically involved. For the operators, it's difficult because the duration of the procedure is very long. You need to have the mindset and the patience that you're going to be able to do it, and it carries some degree of fatigue to the operator, which the why we try to do them together, because it kind of unloads us of these pressures and we're able to work harmoniously and brings us to a higher level of success with doing our procedures.
So you two work together on these
time.
procedures.
All the
And
time.
tell me why you do it and really quickly what it's like.
Sure. So it's usually like a party in the cath lab because you're working with your best friend, right? It's it doesn't work with everybody. I'll say that. There's times when I've tried working with other operators and we're in sync. We know what the other person is trying to do, and the other person's playing quarterback or coach, right? So you kind of transition between those two roles through the entire procedure. The piece that Dr. Pujeda was mentioning about the risk. These procedures, the overall risk of anything bad happening, complications, about 8 to 9%. Mortality rate during or immediately after the procedure is about 1%. That's almost 10 times higher than routine stenting procedures. So with this particular way of having two operators, you're focused on what you're doing. You can't also think about 3-4 steps down the road, which is what he's doing when he's standing next to me and kind of planning how we're going to do things next. And if I get stuck in one thing, I could be lost in that rabbit hole for 20, 30 minutes. He says, okay, we've tried that. It's been 5 minutes. We need to move on to the next thing. And it makes our procedure more efficient, more reliably successful, and it decreases our complication rates significantly.
It's funny. It works very well because our demeanors are different. And our staff loves that about us, but the important part is we have the same goal in mind. When we start doing our procedures, all we want to do is make our patients better. So in a way, we take turns, but we try to anticipate what each other does, and we go through certain protocols and algorithms in our minds. So for example, if Dr. Hira is the lead operator and I see him getting tired or I see him having a difficulty, then I go back to our algorithms. What have we done before? What could be different? And I try to inject or suggest those things. And by doing that, it kind of changes the platform, and it decreases the fatigue. And like I said, the end goal is to be more successful with what we do. So,
how is this procedure program? How is it unique for Pulse?
So the way that most programs do this is with a single operator. They do it as part of their routine day. They don't dedicate time towards doing this. And we were very clear early on that we wanted to have both operators there. We wanted to make sure that we were doing only these types of patients on a particular day, so we had the right equipment there. And it was not just let's just poke and see what happens. It was a planned approach to ensure that we were going to be successful. And so we usually do these procedures twice a month. The full day is dedicated just to these types of procedures. We do 3 of them usually on a particular day. We have all our equipment lined up for from the few days before that. And we've both talked about the case. We talked to patients about the higher risk, and basically have a plan. Like you mentioned about algorithms. We know what we're going to do when the first step, the second step, the third step, and the fourth step are not going to work. We know what's going to be next.
It helps a lot also that our program is supported by our system and as well as our staff. So that brings us a lot of confidence in what we do, and it propels us to do better in what we're doing right now. So that helps a lot.
In our last 30 seconds, what population of the what patient population is this procedure performed on?
Sure. So folks that pretty much have 100% blockage in one or more arteries that either have already had bypass surgery and the bypass has failed. Some people are being referred for bypass again, which I don't think is necessary in most patients. The other is patients who are being referred for bypass surgery because nobody wants to tackle this 100% blocked artery, which is not always necessary as well. So if bypass is good for them, perfect, but there is an alternative sometimes to these types of those types of procedures.
Really quick, what is the recovery time from this kind of a procedure like?
Well, most of the time, the plan is to have the patients come for the procedure, but we send them home or discharge them the same day. There are certain situations when there has been some difficulties and we would like to watch them overnight, so we keep them one more day and discharge them the following day. But most of the time, it's a day procedure.
So, for this specific procedure, what makes you? Do you both make the decision of who a candidate is?
Yes. It's always a team approach on the decision of how we're going to treat the patient. Again, even though the arteries are 100% blocked, we only offer it to patients who have symptoms, and the purpose of that is, can we make their symptoms better? If the patients do not have any symptoms at all, then we don't offer it, even though there's a possibility to open it, because it doesn't add any more to their treatment.
Now, when you mention symptoms, what are typically, what chest pain, dizziness, is that pretty much it?
Sure.
Really quick here?
Chest pain and shortness of breath mainly, those are the common ones we hear about. And it's usually stable in the sense that I know I'm going to walk this far, I'm going to have symptoms, I stop and it goes away. Those are the types of symptoms that patients usually talk about, and those usually improve after these types of procedures.
Well, thank you both very much for your expertise on this. We really appreciate it. We're going to take a quick break, and we will be right back with more Top of the Morning. Hi, and welcome back to Top of the Morning. We've been talking about a new cardiac procedure involving stents here on today's show. This segment, we'll be talking to Lane Wilson, who's a cardiovascular vascular technologist, and David Hoppala, who's an actual patient that had the procedure done. Guys, welcome to the show. Thank you for taking the time to be with us here.
Thanks for having us.
First, Lane, I would like to ask you, how long have you been working in this procedure?
Yeah, so I started in the cath lab as a student in 2008, and I've been there ever since. So this year will be 16 years for me.
16 years doing this. In that time, what are some of the biggest changes you've seen in a little over a decade since you've been doing this?
Yeah, so I mean, as you would expect, technology, right? Diagnostic tools we have. A lot of what we do in the cath lab is X-ray guided, so taking pictures of those blood vessels. But we also have ultrasound that we can use. We can use physiologic tests to actually measure the blood flow through the artery and see if it's significant. Do we need to do something about it and fix it? And once we have that diagnostic information, we have a lot of interventional tools we can throw at that to, open those vessels up, whether it's laser, or we have a great new tool, intravascular lithotripsy, so we can break up that tough calcified plaque.
So, speaking of the procedure itself, we do have some graphics here to discuss what these are. Tell me a little bit about what we're looking at here on the screen.
Yeah, so you can see a blood vessel here. Yellow stuff would be the plaque that's blocking up the vessel. We have a wire trying to come through that plaque here. This would be a balloon trying to kind of go around the side. If you can't really see where that channel is, you can use these tools to kind of see where you're at and try to make a channel to get through that blockage.
So how has this program changed your department in the time you've been there?
Well, the cath lab, kind of by default, any procedural area, surgical area, is really resource intensive. So lots of staff, lots of equipment, lots of supplies, lots of time to do these things. And the CTO program really just amplifies that. So like Dr. Hira and Dr. Bejeda said, they're very intentional about when we do this, how much time they have when they do it to make sure they have everything they need and can successfully perform the procedures.
So with this team you're working with, tell me about what your favorite thing about doing this procedure is.
Yeah. So, you know, in the hospital, you have a lot of different people with a lot of different levels of training, a lot of set specialties coming together, and there's kind of built-in power dynamics in that, right? Dr. Hira, Dr. Beheda are very good about leveling that playing field, making sure everybody feels like they're a part of the team, and at any time can say, hey, time out, this doesn't look right, can we look at this and figure this out? And just creating that culture of safety is something that's really awesome that they do.
You've been doing this for 16 years. How long, and I know the technology has changed, but how long does a typical procedure like this take?
Diagnostic images can be as quick as 30 minutes. CTOs, they can go for 3-4 hours sometimes.
3 or 4 hours.
Yeah.
Okay, and Mr. Hoppala, you have actually had this procedure done.
Yes, I have.
And how long ago was it you had this done?
It seems like just yesterday sometimes, and sometimes it seems like a very long time ago. I think it was about, might have been a year ago.
Just a year. So you in the year before that, how were you feeling before the procedure, and what were you wanting to do before that you couldn't?
Well, I'm 73, so I am getting older. I used to think life just would keep on going forever. Although back 2006, 2007, I had open heart bypass surgery, as was discussed in the last segment. So I did know that I had heart problems. And my grandfather on my dad's side and my dad had obvious heart problems, and my aunt and uncle both died from heart attacks. My dad had open heart surgery. He lived to be 99 though.
Wow.
So it gave me some reason for hope. But back to your question. So I think getting older and then knowing that I've got heart trouble, that it's genetic, I know that I needed to be careful about what I eat. Fortunately, the woman to whom I married has Croatian roots. She likes to cook food, and she knows what is healthy to cook. So I feel very fortunate that way. But still got these genes to deal with. So I wasn't exercising as much as I probably should have. Let's take probably out. I should have been exercising more. And I changed my, what I call now primary cardiologist, Dr. Slim at Pulse. I saw him and he was concerned and asked me about the exercising, because I had been walking some. How far can you walk before you have to take a break? He said, you've got a problem. So that's how I got into this program. And the other part was, I think, as I knew that this procedure was coming up, was right in the middle of COVID, and being able to get a bed for the procedure was really tricky, because there could be an emergency that would bump us out. And I felt depressed. Now I'm trained as a psychologist, that's my work. So I was able to understand, and it isn't an unusual experience for people who have heart troubles to have depression. So it was all the more reason that I felt like what I was doing, getting this procedure done, was important.
I believe what we're looking at here is before and after. and I'm not sure, would this be your procedure? But this is what a typical problem area where they would need to perform this procedure on would look like, and then on the right is after what a cleared up arterial system, I guess, if that's what you want to call it. I'm not a medical professional. But we have a little bit of before and after and how it works. And going back more to your specific problem here, or issue, what was your experience working with this group? I mean, obviously you came out, you look great, you're healthy, we know you survived. Just tell me a little bit about your experience.
Well, there are a lot of people who are part of the team, as you were saying. So then I think that's comforting, because it's too much to ask that the doctors spend all their time soothing a patient. Although it would be fun, it might be nice, but it's unrealistic. People have special jobs to do, and the nurses and other staff were just terrific at helping to get prepared and making me feel comfortable, letting me know that someone would stay in touch with my family out in the waiting area, knowing that the procedure could take a while, so just relax. All of that really was helpful in a really big way, because it can be pretty scary.
In our last minute here, is there anything about this procedure, this process, that you wish you'd known before?
Well, I wish I'd watched this TV program before. I'm just kind of joking, but there's so much that a person can understand about this kind of procedure. I think it is important for anybody who's watching, and if you're having problems like short of breath, get it checked out. My older brother, my brother and I told him he never went to see a cardiologist, and he died from a heart attack.
Oh, I'm sorry to hear that. Well, yeah, that's very good advice coming from somebody who's experiencing it. But that is all the time we have for this episode of Top of the Morning. But on a final note, Bates Top of the Morning is a student-led production of the Broadcasting Video Production Program at Bates Technical College. For more information about the Broadcasting Video Production Program at Bates, please go to www.batestech.edu/broadcasting. I'm Chris Anderson, and we'll see you next time on Top of the Morning.
Thank you, Chris.
Thank you.
Thanks for joining us.